Good morning, ladies and gentlemen. President Jamal, many thanks for your kind introductory remarks and words. It's a special honor and prestige for me today to be here and talk to you the present situation of the nodes and robotic surgery, especially in connection with the day surgery. It was more than a quarter of a century ago when this bike champion, an excellent surgeon, Erich Mühe, first in Birmingham performed the first laparoscopic removal of the gallbladder. From that time, this procedure practically really opened a gate to the future, as it was told by our kind friend Professor Jacques Paris many, many years ago. And really, the devices which we are using during laparoscopic procedures can be directed and moved by a telepresence situation, telepresence movement, as it was outlined by Professor Richard Satava, a pioneer of this thought. And really, a new wave of surgery, the robotic surgery, has started. If you would like to summarize and divide the different types of robots, we of course knew those robots which are used in industry. We use the humanic type of robots, and there are a lot of research work about biomimetic, bio-inspired robots, protein-inspired, even nucleic acid robots, and the nano-robots. And also during the recent years, a special robot was developed for the space exploration as well. It's an ordinary picture of the industrial robots as we all know it, used in car industry and in other parts of industrial work. And here you can see the very famous robot made by the Intuitive Surgical, the Da Vinci, which has a lot of advances. As you know, it has a specialty by which the tremor has been filtered, and even the emotion scale is used for the precise work. The freedom of your hand is really fantastic when you are in the operating room and have a three-dimensional view. What you can see inside the abdomen, it's really that you are feeling that you, the surgeon, are inside the abdomen and can do your precise work. And the precision is also outlined and taken to the single-axis surgical world as well. And even the near-infrared spectroscopy is also added to the Da Vinci system. Here you can see what hopefully no, sorry, I will try to go back. So the precision, the work, as the Da Vinci can produce a precise work, cannot be compared to any other device. Using this precisional work, you can even peel a grape. It doesn't work, sorry, never mind, we'll go forward. Yes. Many years ago, I had the opportunity to take part in robotic surgical course in South Korea in the Yonsei University. And I am totally convinced that that's the way to the future. The surgeon can sit in a comfortable armchair and can do his work precisely, absolutely precisely. And today, because we have the Da Vinci SI, we have also an assistant for our work. The robotic can be also transferred to the microsurgery. In this way, you can do even a retinal vein cannulation. an absolutely precise work, and with a minimal movement, minimal tremor of the surgeon, you cannot do it. But if you use a robot, it's possible. Of course, all over the world, new methods, new devices are under construction to compare and to replace the very, very expensive robotic surgery all over the world. And it's told that in next year a Canadian device, the Amadeus, will be on the market as well. I hope it will work. But I wanted to show how does it really work. No, it doesn't work. Never mind. I can show you that the precision and tired-less work what a robot can do is demonstrated here. We can educate the robot what to do. Afterwards, it can do it precisely, never be tired, never hurt, never make any wound. If you ask a surgeon to do the same, he can do it for several minutes, possibly. That's one of the advantages of the robotic work. I'm sorry it doesn't work. I wanted to show you how an automatic operating room is working. There is an automatic scrub nurse who is giving the devices to the automatic surgeon. Possibly it's also a way to the future, and this new discipline, the robotic surgery, is developing in a fantastic speed. And there are also the humanoid robots. Among them, I have to mention the robotic medical assistant. On the right side, you can see a robot. The size is just as a living person, and you can direct it from far away, even from another country, to go into the bedside of the patient, and you can talk to the patient, and you can direct it, as you can see here. Dr. Petlin in the US is just making a far distance evening round to check the patient state. The patient will see the doctor's face. And there is a camera on the top of the screen, so the doctor can see the patient can see the doctor, and this robot can be guided from far distance, can replace the doctor. There are very precise devices. The next picture, which doesn't want to move, is called a sushi robot. It is just like a human arm with the fingers, and it can do a precise work, just how to make a sushi, how to use it, how to lift up, and so on. It's another very interesting robot is called the Boston robot. It looks like a human body with legs, but it's not a human body, it's a structure. It can go up to the hill, can go down to the hill in different circumstances of the soil as well. These devices can be used for surgical work as well, if you minimize it, if we use it for human purposes. All over the world, there are a lot of surgical works as well, how to produce the modern and very useful robot. And biomimetic or bio-inspired robots are also under development, just like it was made in Singapore. Singapore's national dish is a favorite chili crab. And as the doctors, the surgeons, had a wonderful dinner in Singapore, they had made some sketches how this works, and later they wanted to produce the same movements added to an endoscope. There are a lot of innovations to follow how the worms are moving, how the octopus can work, and also even the movement of a kangaroo is put together, the movements in a mathematical formula, and it's transferred to a mechanical structure. Probably that's another way to the future, to use an reconfigurable endoluminar system. Several small parts, not larger than 1 centimeter, is put together, is swallowed into the stomach, and it can be used for a special task in the future, whether there is a bleeding point to stop the bleeding or to suture a hole in this area as well. And there are the so-called protein-inspired robots. The structure that you can see here is not larger than 1 centimeter. And its nickname is the Swiss knife. And its movement is inspired how a nucleic, a protein structure is built up, the movement and the development of this structure. You can see also the nano robots. The nano size is today is a very fashionable expression. Today there are possibilities to build up the so-called nanotubes made by the fullerene, which is a carbon network. And you can build up in a nano-sized car. It's a nano car. And you can give special instructions to do special work inside the bloodstream to capture bacteria or viruses as well. That's the configuration as well. And you can check it, how does it work in a microscope. And there are even smaller robots, the so-called nucleic acid robots. And at the Harvard University, they could open a desoxynucleic acid structure just for the same purpose that I've mentioned, to capture bacteria. There are also robots used at the space exploration. Right, it also doesn't work, never mind. And it's a recent photo made 2 weeks ago. The NASA experts revealed that possibly if you want to spend many spacecraft to the Mars, there can be unforeseen complications, radiation hazard, temperature changes. So it's the best thing at first to send a humanoid robot who can mimic the gestures of a man and can fulfill special tasks as well. So just recently, a humanoid robot was sent to a space station, and recently they came back, and it's just a funny picture how they are working in the space lab. That's the situation which doesn't exist today. So it's impossible to go to a shopping center to buy a large robot, take home, put to the grandma. This robot is doing the laparoscopic cholecystectomy while you are watching the Barcelona game at the TV. It doesn't exist. But just recently, 1 month ago, there was a statement in the US by the American Congress of Obstetrics and Gynecologists. And it was, the summary was that this robotic technology doesn't improve practically the patient care, and it's very, very expensive today. The price is more than 1.7 million US dollars to use it, and the outcome is surgery practically is directed by the surgeon's skill. There was only one very important advantage of the robotic surgery. The hospital stay was shorter than any other surgical procedures. Another statement just recently, 2 weeks ago at the SAGES meeting in Baltimore, that the study should focus on combining clinical effectiveness and the cost effectiveness in the future. So we don't know precisely what's the surgeon of future, but certainly we have a future. The other interesting aspect of the modern surgery, to use the natural orifice of the human body. It was an old desire in the mankind and of the surgeons to find a way how to get inside the human body through the natural orifices, through the nose, throat, vagina, even in rectum, without a scar seen from outside. What are the problems we have to solve during the nose surgery? The access, the maintenance, and the closure. So every step is a challenge for the surgeons. It's a sketch. How can we imagine this surgery? But it's not only an imagine; it's a reality. Special endoscopes have been developed for suturing, for preparation, for cutting, for closure, and so on. And many years ago, 10 years ago, was performed the first transgastric appendix removal in India by Dr. Rao. And it was a very impressive sight as the appendix was removed through the esophagus coming from the mouth. There were, of course, previous stages of the development of nodes. For example, the transvaginal route for surgery is not a new invention, because transvaginal hysterectomy is an old method, and sometimes together with the uterus, the appendix was removed accidentally in the past. And in 2007 started the transvaginal surgery, at first in Brazil, Dr. Zoron, and later in Europe, Professor Jacques Maresco performed this operation. And the very first transgastric removal of the gallbladder was performed in Oregon, in Portland by Lee Swanstrom, and he performed about 10 procedures. Afterwards, he had to stop. Why? Because no insurance company wanted to cover this. They thought it's very serious, possibly a lot of possible complications accompanied the procedure. Well, the closure of the stomach, when we remove an organ through a hole of the organ, it's a very precise work. And as you saw, a small leak can sink a great ship. Years ago, there were a lot of new published papers about the advantages of nodes. It still goes on, but the speed is a little bit in the background. Fantastic devices were developed, just like the Olympus Endosamurai. And it's, we don't know that all the orifices of the human body can be used for the surgery. The Time magazine added the nose technique is one of the most genius idea which will determine the future. We have to think of whether it's really a right way to find the liberty, the solution. Even this technique is added to the single incision surgery. There were a lot of critical papers telling it's a surgical pilgrimage. It is a medicine or medicine, or it's a dirty way to the gallbladder. Well, there are new directions. We have to have a look at to the future. We don't see, of course, which are the final solutions. Probably a lot of parallelly used procedures are in front of us. That's the dream. There is a patient, has a problem, goes to the hospital, get a sterile gown, be operated during 1 hour, and can go home without any problems and can continue his work on the next day. In this question, notes, robotic surgery, usefulness, everything done in 1 day, we have to combine the questions: business, the patient safety, the technical progress. And we have to know that on the other side of our sophisticated, absolutely modern devices, there is a man, a patient. And we have to be directed by our inside moral compass. And of course, the most important, the patient safety, the salus aegroti. That is summarized here by a surgeon who is just starting the operation, absolutely concentrated to the forthcoming procedure. But I have to show you, as Professor Jacques Périssat, one of the pioneers of laparoscopic surgery, is absolutely very happy when he is standing in Singapore at the skills lab of the university, showing his optimism for the future. Thank you very much.